Okay, so I just want to introduce everybody to one of my fellows, Casey Blanton. She'll be presenting today on Cavus foot review, a couple cases and good reviews. So Casey went to University of Cincinnati for her residency, and then we got lucky enough to get her for a fellowship up in Cleveland, and she's done a great job with us so far. So pay attention and participate, please, for everyone watching from home. So take it away, Casey.
All right, yeah, thanks. So yeah, I kind of want this lecture to be a little bit more case study interactive. So there's going to be some questions, so don't be nervous. At the end, there is a harder case that I don't expect you guys to get right. And if you guys do, you're way and beyond right now. But just feel free to ask questions along the way, and we'll play it by ear. So to get started, I first want to go into more of a subtle Cavus foot. So a great article, oops, one second. A great article that's out there is by Pomeroy, which you guys probably should all read if you haven't at some point. It's a good algorithm, and when you're in residency, that's what you really should try to start forming is algorithms. So when you're out in practice on your own, you have a protocol that you follow every time, or at least for the most part. So Pomeroy in 2014, he's an orthopedic surgeon. He had this algorithm where you start from proximal to distal, kind of like you do with a flat foot. So his first test that he wants to do on everyone is a silver sculpt, which I kind of agree with, kind of don't agree with when it comes to Cavus foot deformities. But what do you have to be careful of with Aquinas when you're dealing with the Cavus foot? Does anyone know? Correct, yes. So pseudo Aquinas. So you're going to see that with what, more interior Cavus or posterior? Anterior, good. So some people are saying anterior. So you have to be careful for that, because when you go to correct it, obviously you don't want to give them a calcaneal gait and another issue where they get a heel ulcer or something along that line. So just be cautious of this first point and take it with a grain of salt. The second one, obviously, is the Coleman block test. So if the Coleman block test is positive, what does that mean? Any takers? So positive meaning more that the varus deformity corrected. Yeah, so it's forefoot driven, and also it tells you somewhat about the flexibility of the hind foot. So that's another big point. So if it remains in varus, what type of surgical treatment options do you have? So someone's saying dorsiflexor wedge osteotomy. You're thinking right along on the way of osseous, but you want to go more towards the hind foot here. However, a lot of times, even when you correct the hind foot, you still want to pay attention to the dorsiflexor wedge osteotomy, because you want to make sure the forefoot corrects as well, because sometimes it's semi-reducible where it doesn't correct all the way, but there is some correction there. And then the third point is first ray mobility. So take the first met and see if it levels out to the lesser metatarsal heads. If it does, usually you don't need anything. If there's resistance there, the first thing you want to start with is a peroneus longus to brevis tendon transfer. And if you're still having issues, then that's when you'll do these dorsiflexor wedge osteotomy, or you can do more like a dorsiflexor lapidus, depending on what type of case you have. And then the last thing that you don't want to forget is lateral ankle instability, because with these Cavus cases, a lot of them have chronic issues with rolling their ankles a lot. They'll have ankle arthritis, pain over the ATFL. So that's something you don't want to just fly over and skip over. So moving on. This was just kind of a summary of that. So if you guys want this, I actually, when I was a fourth year student, was assigned this article and they wanted me to make a summary of it. So if you guys want this, just email me and I can get you guys my email at the end. So case number 1, this was a 45-year-old male, relatively healthy. His major complaint was he just had pain outside of his foot when ambulating. He was a hospital worker, so he was on his feet 8 to 12 hours a day. At this point, has failed conservative options. He's worn braces, orthotics, has pretty much done it all, and now is coming to us for more of a surgical consult. So here's his x-ray. Does anyone want to read it or give us the impression? Any takers?
I can do it.
Okay. What's your name?
Christina.
Christina. Okay. All right. Go ahead.
Okay, so the first thing I notice is that our calcaneal inclination angle is increased.
Okay.
When I'm looking at Miri's angle, I can see the bisection of our talus would go over where the first ray bisection would be. So
Okay,
normally,
so is that positive or negative?
well, normally this would mean positive, right?
Okay. Mm-hmm.
So this has to do more with Cavus deformity versus if it was negative, it'd be planus, right?
Correct.
And then there's nothing else super noticeable to me on this. I mean, I can see the cuboid pretty well. It just looks like a general high arch, but maybe primus elevatus. Like we have a really first ray.
Yeah, so it's actually not too bad of a Mary's angle. If you look at the cortex of the second metatarsal, it's going right through the center of the first metatarsal, so that's exactly where you want it. So I would say, the forefoot alignment is actually pretty good. It's more that this calcaneal inclination is high, like you said, and then there's a posterior line. What about the joints? Do they look like they're relatively healthy joints?
It's hard to see on here, but maybe the talar navicular doesn't look so good. I don't really see too much like arthritis dorsally where I would expect it.
Yeah, so not too bad. So going on to the next x-ray. Oh, one other big thing is Hibbs angle that you want to look at. So that's the bisection of the calcaneus, and then this line with the first metatarsal. Under 45 is normal, acceptable. Once you get over 90, that's when you're really getting severe deformity. So another thing to consider with those lateral x-rays. So, okay, what about the AP? Anything stick out here?
I mean, we have a medial oblique in a AP, but nothing super. I mean, would we be looking for like maybe a forefoot valgus situation, or
You more see that from the lateral x-ray.
okay?
But an important thing to look here on the AP is how much talar head covering you have. And so
it's
this
pretty
is
much
extremely
100%, right?
right. All right. And then also like the TC kite angle, which that would be, yeah, that's decreased. So another sign of the cavus. So moving past the x-ray, physical exam questions. What do you want to ask me? And I will try to give you the answers as a patient. So you kind of saw this x-ray, you saw the patient came into the office, you saw the x-ray before you went in, and now you're kind of like, okay, what do I have to really take a look at?
Pain to palpation?
Okay, where?
Yes, I'm asking where.
So they, okay, peroneal tendons, that's good. Yep, because a lot of them have lateral ankle instability issues. The medial calcaneal tuberosity, that's another one. You'll see plantar fasciitis pretty often. Where may you see callus formation? Fifth mat, okay. And first, yep. Okay, so if you're one of the residents and you're worried about lateral ankle instability, whether it's flexible or rigid, if it's forefoot driven or rear foot driven, and you're presenting to me as attending, what type of test do you want to tell me about? And what's okay, Coleman block. So let's say the Coleman block here is negative. Any other tests? So first, let's back up a little bit. If the Coleman block test is negative, this is telling us, one, that we still have a rear foot varus deformity. So we're going to have to do a procedure of some sort in the rear foot with osseous osteotomy, a fusion, something along that line, in addition to potentially a forefoot. So we know that as one. So now, what's other physical exam findings? Okay, silver scold. Okay, let's say this is a positive silver scold. Good. Anything else? Good. Anterior jaw. So anterior jaw is negative. So he's doing he's pretty stable lateral ankle wise. Okay, so you guys are hitting more of the bigger points here. So this guy's relatively flexible, good range of motion to his ankle and subtalar joint, negative Coleman's tests. The first metatarsal reduces to the level of the lesser metatarsals, the positive silver scold, and a negative anterior jaw. So with this Pomeroy article, does someone want to kind of talk through me what their plan may be for surgery? And come up on the microphone.
Well, since his Coleman's is negative, so we're thinking more of like a rear foot calcaneal osteotomy.
Okay, perfect.
And then positive silver skull, so he probably actually does have Aquinas rather than pseudo Aquinas, so TAL
Correct.
might not be a bad decision. The negative anterior jaw, his ankle instability is probably pretty solid, may not need any type of rostrum or adjunctive procedures
Awesome.
maybe on the lateral.
So with those two things you said that are significant, you're booking the surgery. What are you booking?
In terms of like procedure selection?
Yep, you got it.
Yeah, probably a Dwyer, like a lateral opening
Okay.
osteotomy to close that down, and then probably like a just little Hulk Achilles tenotomy, possibly.
So you're right on track. So you're fixing the two things that I wanted you to fix. I will say with Cavus recons, the TAL is kind of aggressive. If anything, you probably want to do more of such of a gastroc recession or a Baumann a little bit higher up, just because when you're doing the lateral displacing calcaneal osteotomy, you can actually break that medial cortex and slide the calcaneus up. And by doing that superiorly, you're actually decreasing the tension on the Achilles somewhat. So you just want to stray away from being too aggressive with these Achilles lengthening. So what we did was a gastroc recession and then lateral displacing calcaneal osteotomy. But Dwyer is another great option for this. And you may have the question like, okay, when do you do the Dwyer versus lateral displacing calcaneal osteotomy? A lot of times this decision is done intraoperatively. So your first cut is the exact same. And then say the varus isn't corrected as much as you wanted, then you'll just kind of slowly go in with your blade in and out, and kind of slowly whisk some of that bone away so that you're getting that closing wedge. And you do it till whenever fits the correction there. Alrighty. So next one. So this lady came in, 57 years old, complaining of lateral foot pain. She's had multiple ankle sprains. She has ankle pain, and has some, she feels like she doesn't have as much range of motion there as she once had. She's having heel pain. Overall, pretty healthy again, has failed conservative measures at this point, and more wants something done surgically. So here's her x-ray. Does anyone want to take a stab at reading this?
Yes. Hello.
All right, thank you.
So one lateral X-ray, you have increased calcaneal inclination, decreased talar declination. Mary's is positive, and there's almost
Okay.
like a plantar flexion occurring at the metatarsals. Bell-shaped cuboid and posterior break.
Okay. What about the joint spaces?
Joint spaces do not look like they're diminished, except at the anterior ankle at the talar tibial joint.
Good.
I don't know if
Good.
that's joint space minimizing or not, but there's also an osteophyte there at the head of the talus, on the neck, dorsally.
Awesome. And one point that you mentioned was the plantar flexion of the forefoot. I can tell here there's actually a little bit more plantar flexion of the first metatarsal because, again, if you look at this the second dorsal cortex of the metatarsal here, oops, you're seeing that it's above the 50% marker. It's above the midway point in the first metatarsal. So the first metatarsal is plantar flex in relative to the second metatarsal.
Thank you.
Does that make sense?
Absolutely.
Okay. Okay, here is more films, and what do you see on these? So we're looking at the right side here. So this is just showing contralateral, bilateral, sorry. So let's start with the calcaxial. What do you see there?
Definitely seems like it's angled like in a more varus position.
Okay. So calcaxials are is an X-ray that you guys want to be ordering with these deformities. So yeah, you're looking at the varus deformity from the tibia to the calcaneus. So good. What are you seeing on the AP here?
Much decreased talonavicular coverage.
Yeah, so really, yeah, the head is completely covered there. Okay. So physical exam. So I already told you that, you know, she's having heel pain. She's had a history of spraining her ankle. What test do you want to do here?
Anterior jaw and talar tilt.
Okay, so let's say the anterior jaw is positive. So you're manipulating the foot. Anything you want to kind of feel for? Silver skull, someone mentioned. So with this patient, she has decreased ankle range of motion with a hard osseous end stop. So at the end range of motion, it's a hard stop. What made that indicate? Correct. Yeah, there's the osteophyte that you're gonna have to take care of potentially. Also, she has a little bit of crepitus there, let's say that. Not terribly, but she does have a little bit there. So osseous decline is good. What big test are you guys missing? Coleman, yep. So with this person, he kind of semi-reduced. So there's still a little bit of varus deformity remaining. There was definitely a part of the forefoot that was contributing. So let's say semi-reducible.
Can you please go back to the AP x-rays, please?
Yep.
Is the adduction worth worrying about on the metatarsals, or is that really just the angle of the x-ray?
It's more the angle. It's not, yeah, it's not dramatic or significant. He's more actually in the inversion there. That's kind of
Okay.
what you're seeing.
Yep, thank you.
So significant findings here. Panel palpation to the medial calcaneal tuberosity, indicating what? What would be your diagnosis for that? Heel pain, let's say it gets worse right when he gets out of bed. Gets a little bit better. Yep, yeah, so plantar fasciitis. He semi-reduces, the first range mobility is rigid. Subtalar joint range of motion is within normal limits. And he has a hard stop at the end range of motion for the ankle and has a positive anterior jaw. So with these findings, you're kind of talking to your attending, what procedures do you want to do on him? And kind of just take it step by step. So I'm seeing gastric recession, chilectomy, awesome. So that's more what I would go for. It's more of osseous equinus. So I'm gonna kind of be more cautious to doing any lengthening at this point. Rostrum, good. So if the first metatarsal is rigidly plantar flex, what are we gonna do there? Dorsiflexury wedge osteotomy, good. Now it's semi-reduced, so now we have a little bit of calcaneal varus that we know about. What do you want to do there? And I'd like how someone said the longest to brevis tendon transfer. Even if you're doing the dorsiflexury wedge osteotomy, that's always a good idea because the tendons are essentially your deforming force. So there's papers out there that say even if you're doing a triple arthrodesis, you still should be balancing out those tendons. So pronator longus to brevis with the dorsiflexury wedge osteotomy is big. So you guys hit pretty much most of them. So what we decided to do is a plantar fasciotomy, an ankle chilectomy with the ankle arthroscopy, clean out the ankle, try to give her some relief there. Dwyer or displacing calcaneal osteotomy, which, like I mentioned before, you can kind of decide intra-op how far you want to go with that. The longest to brevis tendon transfer, the dorsiflexury wedge osteotomy, and the rostrum. So I guess my goal for you guys here is just really kind of break things down. Don't just be like, okay, this is the Cavus foot. I know in class that we learned about a dorsiflexury wedge osteotomy and a Dwyer and those things. Kind of really focus on, okay, what's their diagnosis, what's their assessment, and treat each of those diagnoses accordingly. So here's some x-rays for that. So when you're doing the slide, how much movement can you get in millimeters? What's your range? Five to 10, good. Yep, and we have a question here. So how can you fixate the first metatarsal? And where should this osteotomy be?
In case that's Dr. Rosante talking. So he's going to ask questions. He's going to ask questions, and you're going to ask.
Okay. So where should this osteotomy be in relative to the first metatarsal anatomically? Okay, base. Let's get a little bit more specific. Good. So metaphyseal, diaphyseal area. So about 1 centimeter away from the articular joint. Good. All right. And then what size screws are you using for your slide? And this can be a range. 6.5, good. So 5.5 to 7 about is what I've used in the past. Okay. And I want to point out here, you can see that we slid that posterior tuber superiorly. So that will, like I mentioned before, decrease that tension on the Achilles. So in some regards, you are lengthening it through that indirectly. Okay, well, let's move on here. So we covered subtle Cavus foot pretty good. So knowing the algorithm and residency will go far. So just kind of break it down like I mentioned, and then attack it in that way. So another thing that you need to know for boards, I've done a few times, but definitely not as frequently as what I just showed you. But midfoot osteotomies, these are big, especially when it's more of a sagittal plane deformity. And when deciding what midfoot osteotomy to do, a big question you're going to have is, where is the apex of the deformity? So what's that phrase that you use when you're finding that apex? It's a 4-letter word, cora. Good. So if you're looking at this x-ray, where would you say the cora is? You could say TMT. I would say it's a little bit more proximal to that. Yeah, more at the like navicular cuneiform area. Okay, so with the apex being at the navicular cuneiform level, what midfoot osteotomy have you guys learned about that's about at that level? Cool, good. And so when you're throwing, your K-wires for this, because this is going to be a dorsiflexury wedge osteotomy, you're going to be aiming it centrally through the cuboid, or midway through the cuboid, and then right at the NC level. And then you can do another one just distal to that, to kind of align where your cut's going to be and how much wedge you actually want to take. You can kind of see that here at this bottom picture. And this picture on the top right. So when you're doing a cool osteotomy, don't just think, that's the only thing you're going to do. You still got to address everything, working from rear foot to forefoot, correcting the calcaneal varus if you have that. And then with the coal, you're doing the sagittal correction for the midfoot. And you can do a little bit of abduction with it too, depending on if you want to take a little bit more medially based, or sorry, laterally based, to close that down somewhat. Okay, what about this one? Does anyone know say you're taking the wedge, truncated wedge from the tarsometatarsal joint? Do you guys know the name for this? Jaws, yep, yeah. And great point with the Steinler stripping. So when you're doing these osteotomies, it can be challenging to get these reduced, and you're going to be resisting the plantar fascia and the whole plantar attachment. So you want to release those to free up everything and make your reduction a lot more attainable. Okay, so we're getting a little bit more difficult here. Does someone want to take on reading these x-rays? So overall, this is a 76-year-old female. She had a stroke a couple years back, and now is walking on her tippy toes. She can't get her heel down to the ground. She's been in braces, and now is starting to get some irritation laterally on her ankle, and she also wants surgery. Any takers? I know this one's a little bit more difficult, so I definitely understand that, and I'll help you walk through it. Come on, guys, I don't need to do this. This is for you guys.
I can do it.
Okay, thank you.
Yeah. So the first question I have is like, so these are non-weight bearing, right? Is she actually able
These
to
are
eat?
actually, these are weight bearing. So this is like, she's contracted.
Okay.
She's very rigidly contracted.
So it would seem that maybe her posterior muscle group's the only thing that's really working. Her extensors aren't. Is that fair or no? From her neurologic deficit?
You could say, yeah, you could say that. Yeah, her tibialis anterior is probably really weak, and her PT is overpulling, as well as her gastrocsoleus complex.
Okay. Is it also okay to say that she has osteopenic bone, or is that just the radiographic view? I mean, she is older.
No, you're right. You're
Okay.
right.
And then it looks like she has a lot of arthritic damage, bone loss to the lateral, wait, let me see, to the medial column.
Medial column. Mhm.
Yeah, the talus looks
What about the rear
dislocated.
foot? Okay.
Is that what you were going for?
More of the joint spaces.
Okay. They are almost gone.
Indicating.
Arthritis, possible autoeffusion, I guess.
Okay. Also, you'll see like the more flattening of the talus. So you'll see that like the calcaneus, the pitch of the talus to the calcaneus, they almost go parallel to each other.
Okay. And then is the navicular like sandwiched and squished medially as well, or?
So I'm glad you mentioned that. So here, so normally when you're doing, say, normal gait, when you have internal rotation of your foot, your tibia is externally rotated, and usually your talus does the opposite. Here, almost the talus and the tibia are doing the same thing, and that's because the tibialis posterior muscle tendon is pulling on that navicular so strong it's almost pushing out. The talus is becoming so covered it's almost getting dislocated or subluxed.
Okay.
So with that being said, we have a very tight tibialis posterior tendon. So keep that in mind for when you're thinking of surgical procedures to do. And then also, what in the hind foot, which you kind of probably already mentioned, what also is really tight here that you're going to want to release. Yeah, the whole Achilles.
Okay.
So this is the point where it's so tight where you don't even want to do a TIL with the percutaneous stabs with the 3 hooks. You want to just do a complete tenotomy. Okay.
Thanks.
So who wants to take on the plan for this? If you see this and you're going to the tendon and the tendon is like, okay, what do you want to do?
I can take it. So you want to
Okay.
reduce that deformity, but there's a lot of pulling force from the tibialis posterior muscle. So you'll want to release that.
Okay.
So you can do you can just do a complete resection of that, or you can do a tendon transfer if you want to retain any functionality, but that'd be out of phase.
Okay.
You want to do, like you said earlier, the complete Achilles resection as well.
Okay. Do you think this person's going to get away with just osteotomies to correct her deformity, or do you think more fusion at this point?
I think fusion, but I mean, you have to prep those. I mean, some of the midfoot's already fused pretty well, but you still need to correct that. It's not, and put it in a better position.
So you're going in for surgery. Are you going to prep? Which joints would you like to prep?
The talar navicular joint.
Okay.
And you probably also want to fuse the ankle joint as well.
Okay, and if you're fusing the ankle and the talar navicular joint, what other joint do you want to fuse?
The SCJ.
Subtalar joint, yeah. So you could definitely argue a pantalar arthrodesis here. We did not do the TN with this one, but definitely you could argue that.
Okay.
So our plan was a TTC fusion with the intramedullary nail, a PT release, and the Achilles release. Now, after doing that, you may have some forefoot deformity left. However, just be cautious of doing too much at one time. So don't be afraid to stage things. So we stopped here and she was happy with how everything turned out. And honestly, her forefoot wasn't too terrible. So we kind of just left it as is. But if you're doing this much in the rear foot, consider staging things. So there's not so much swelling and complications for dehiscence along that line. Good. Okay. Oops.
Dr. Blanton, I would think a pretty dumb question I want to ask about this. Since you said you want to do like an open recession, what position would you be able to do that with the patient supine? I've never seen an open recession done with a supine position, so I was just interested.
Well, for this one, we did just a straight Achilles anatomy, but when you're doing a gastroc recession, you'll just need, and someone supine, someone just needs to lift them up like high, have someone hold them up high, and you can do it like slightly medial to midline, or you can do it just medially where you're doing like an endoscopic. You just open it up a little bit bigger, and you can use a rectal speculum or a gynospeculum to kind of find that plane and insert it medially, and then you turn the speculum and open it up, and then you see the aponeurosis just right there. It's one of the easiest ways to do it, and you just take a long blade and snip it.
Okay, awesome. Thank you.
Does that make sense?
Yeah, it does. Okay. I think it was just more of a lack of experience on my part, but yeah, that does sound very interesting. Thank you.
And you're welcome. And it is kind of surgeon preference. So some people like to do it more midline. And it definitely is easier when you're prone for that, but you can't do it supine. It just, requires someone to hold the leg for you, or you can actually frog leg them as well, or you just bend their knee and internally rotate their leg, or externally rotate their leg. Okay. So just getting a toll here, I guess. Do you guys want to kind of go over the step-by-step for eye of nail? Okay, so one of the hardest things with doing the eye of nail is getting the main guide wire in the right spot. And that's where, if you don't have a good way to do this, it can be time consuming, but it's also something that can go really quickly once you get some pearls down. So a good way that I learned in fellowship actually is taking, before you start, you take a Stuyvesant or a thick wire, and you want to align it on the lateral view, dead centered down the axis of the tibia. Once you do that, you have it lined up on the tibia. I'll get a foot model here 1 second. So when you get it lined up on the tibia, you can take your wire and kind of go like this and have someone mark right along that wire, and that will tell you how anteriorly you need to go with your guide pin. And then you also want to take a calc axial, get that dead center, which you're seeing here on the right, and kind of do a sweeping motion like this, where you mark it with a marker too. So you're going to have these two lines that intersect, and that's usually the perfect spot to start your guide wire insertion. So that's just kind of a nice trick to remember when you enter residency. You may or may not be taught that. So that's a picture of my foot. So so there's that, kind of demonstrating
Dr.
that.
Blanton?
Yeah.
So to summarize what you said, make sure I got an understanding of it. Laterally, you want to be centered on the tibia, and then AP, you want to be centered on the posterior calcaneus?
So actually, you're taking a calc axial, and you want that to be dead center in the calcaneus. See
Thank you.
here? So this is a
Yep.
calc axial. Yep.
Dr. Blaine,
Yeah.
got a quick question. So kind of like what you're talking about the cora, going back to the x-ray, where would you say the cora would be for this deformity?
For this one, I would say more so at the rear foot, ankle subtalar joint. Actually, I would say ankle. It's
Okay.
predominantly at the inversion, rear foot, and Aquinas.
Thank you.
Mm-hmm. Okay, so now you got the alignment here. So you insert it partially, you don't want to just go blasting all the way through because you want to make sure it's right. So you're continually taking fluoral imaging between lateral and AP to make sure you're in a central aspect in the ankle there. Once you get to that level, you're going to keep going farther, and it may not be perfectly aligned as you go proximally, but a lot of times they'll hit that cortex. As long as you're going slow or oscillating, it'll kind of follow that cortex and go in the right projection. So once you get that in there, you'll first drill with usually like a 7mm drill, and then a 9 just to about the isthmus area here. And then you'll start doing the larger diameters. So does anyone know how much further you have to go when you're reaming? Size-wise, say your nail, is 11mm diameter. What size do you want to ream it? So 1 to 1.5 millimeters bigger. Not centimeters, but millimeters. And then with this one, this was Medline's intramedullary nail. And so what's nice about this one is they have a P to A screw, but they also have a medial to lateral, or lateral to medial screw as well. And what's nice about that is sometimes, well, first, they're converging, they're not going at the same direction, so it adds a little bit more stability to that placement. And you will see some nails have just 2 P to A screws. I've seen personally a lot of those screws back out just for that reason, for not converging. So this is a nice nail for that factor. But when you start to do the screw placement here, with this particular one, you do the P to A one, and then you do the lateral to medial one in the talus, and then you work proximally. And proximally is where you're going to start doing the compression. So here, we actually put a drill all the way across at this lower level here. After we did this, you can take an internal, it's almost like a screwdriver that you put at the end of the nail, and you can get some internal compression with it, as well as external compression that they have on the jig there. So once you do that, you kind of lock in the screw up here, and then you can take this drill out, that one that goes all the way across, and replace it with a screw. And then you can put a screw up here proximally. You don't have to. If you're doing somewhat larger, you may want to consider it, or if you want a little bit more stability. But sometimes making it not as rigid is better for it as well. And you have some, kind of like doing an external fixator when you're looking at 2.0 wire versus 1.8 wire. Sometimes too much rigidity can get in the way of healing, I guess, and you want some little bit of dynamization there and some movement. Okay. So there's that. Okay, so here's a quick question for you guys. say, what if the ankle was not degenerative, and say this patient just had a younger or more progressive neurogenic deformity and they're more younger? What's kind of like the board's question and answer for that? Let's say this person has CMT and it's a progressive neuropathic deformity. Triple, good. So in addition to the triple, what else do you want to do? Okay, so Achilles yeah, lengthening of some sort of the posterior complex, but also, so what two tendons are, or what two muscle groups are very weak with CMT? So the tibialis anterior, and anyone else have it? Okay, someone said peroneus brevis. So those are weak. So if you're doing a triple arthrodesis, what other deformity may you have, knowing that the tibialis anterior is really weak? Drop foot. Okay, so what can you do for drop foot? You know the PT is really tight. Okay, good. So PT tendon transfer. So you go ahead and take that tendon, take it through the syndesmosis anteriorly, and then reroute it down to the dorsal foot. Lateral cuneiform is a good one. Cuboid you can do, and even the middle cuneiform as well. Okay, so someone mentioned the Jones procedure. Does anyone know what the Jones procedure is for concerning Cavus recon? Or let's step back. What deformity are you going to see when you do a Jones procedure? Okay, it's part of it, plantar flex first met, but also hallux malleus. So a good reason to do a Jones procedure is with hallux malleus, you take that tendon and reroute it to that first metatarsal and dorsiflex it with that pull. So with plantar flex first met, but also you're getting rid of that plantar flexion of that IPJ, and you're going to want to do what other thing with the Jones rather than just the tendon transfer of the EHL? Fuse IPJ. Yep. Yeah, so when you're thinking about doing the Jones, think one, do they have a hallux malleus and a plantar flex first met? If so, it's a great option. Okay, so we're gonna get a little bit crazier here. This is a tough one. So this guy actually came in this year, 39-year-old guy with CMT. His right side's a lot worse than his left. And he also had a limb length discrepancy, which he had a lengthening about 10 years ago with an external fixator frame, and he really does not want one of those again. He did fracture his mid-tibia as a teenager, and he has this small deformity there, but not really significant. But here's his x-rays here. So does anyone want to give a shot at this? And when he came in, I mean, he is very inverted, walking on his toes. He can't get his heel down either. Has tried everything conservatively. He's actually a construction person and has done really well considering his deformity here, but time for some help. Any takers?
I can do it.
Okay.
So we're focusing on the right leg on the AP, starting more proximal. It seems like he has a pretty severe externally rotated tibia on the fibula. It looks like there's some large covering. moving more distal, ankle joint looks pretty, I wouldn't say well aligned, but the joint space, I see some lucency there, so I wouldn't say it's completely arthritic. The talus looks to be more like dorsiflex and abducted, I guess from the constant supination, with some arthritic changes or osteophyte formation more along like the head and neck area of it. Definitely can see the inverted position of the calcaneus and what also looks like a supination to more of the forefoot.
Good.
And then I guess I couldn't judge based on this view of like the quality or the integrity of the first mat, whether or not it's possibly plantar flexed rigidly or not. The soft tissue around that lateral, where that looks like that tailor head is poking out, it seems to be a little increased.
Okay, that's actually a really good job. That's there's a lot going on there. So I'm very impressed that you picked up the external rotation of the tibia, so that's great. So, oops. What I was going to say is kind of so when you're trying to figure out how to correct this, you really want to break it down into sections. That's really what's going to kind of simplify this to you, because probably at your guys' stage right now, or even as first, second year resident, you're probably like, oh, oh God, this is a lot. So kind of just break it down. So here with looking at the tibia, from that old fracture, there's like about a 7-degree valgus deformity there along the anatomical axis, which, speaking of anatomical axis, do you guys know the difference between that and mechanical? So mechanical is when you're going from center of the proximal joint to center of the distal joint, where anatomical, you're more going down the intramedullary canal within that central third of the bone. So he has a small valgus deformity, but not crazy significant there. Ankle joint wise, this is showing his left to his right. You're looking at his, his tibia to his talus. They're about similar on both sides. He may have a little bit of a recurvatum, but not substantial. Here as well, his ankle joint, like you mentioned, is not terrible. I would say there's some narrowing of the joint there with a little bit of osteophytic changes, but not terrible. So here's his CT. So what do you notice about the talar head here to the navicular? So his talar head is almost completely lateral to, completely laterally to the navicular, to the point where it's getting uncovered. So with Cavus, it's typically covered, but now it's almost going the opposite. It's so dramatic that it's getting uncovered. Okay. And here's kind of like a calc-axial view of the heel, but through a spec CT here. You can see the varus deformity of the calcaneus and also dramatically into the forefoot. Okay. So kind of breaking it down, a recap for what we're seeing in the tibia and the rear foot. We're seeing a small 7-degree valgus, the mid tibia, significant external rotation, rear foot varus, and equinus. So here is more of a lateral view of the foot. So anyone want to say where the core is for this one? Yeah, so at the TN level. Okay. Cog inclination, is that normal? Yes, it's actually not bad. So inclination is not too terrible. What about the talar declination and the Hibbs angle? Yeah, so it's really low. So the Hibbs angle is probably like a 90-degree angle here. Okay. Mary's 22 and has a pretty substantial metatarsus adductus. So the plan is, it's going to get complicated, but you kind of just want to break things down. So the findings that we have is 1, Aquinas. We know he has severe arthrosis globally, pretty much. External torsion of the leg, barefoot varus, a limb length discrepancy, and then global plantar flexion and adduction of the midfoot. And the reason why I put these in different colors, because I kind of want you guys to lump them together with a procedure choice. So does someone want to kind of devise a plan here? Any takers? This is the last case, so we're almost done. Anybody? Okay, well, for the sake of time, I'll keep going. But yeah, you want to do a fusion procedure for sure. Osteotomies are not going to cut it here. So the way I kind of broke this down is, okay, Aquinas, we're going to do an Achilles tenotomy because his is extremely contracted. For his varus deformity and inversion, you want to release the PT tendon, kind of like the last case. You're going to want to do a Stanley stripping to kind of allow that contracture there to be released. And then also, when you have someone in this deformity, it's really hard to get this reduced. So how we thought about going about this is actually doing a talectomy to kind of get everything loose and making sure we correct the deformity the best we can, rather than trying to save the talus there. But because he has a limb length discrepancy, you could argue to save the talus 100%. And I actually, when we were going through this case, several months ago, I kind of argued to keep it. But my attending has had really good success with implants. And so he rather go with a smaller titanium implant. Once we get it reduced, fit that in there. With it being smaller, you can still reduce it well. And then the implant itself, maintaining some of that length there the best you can. But then for the forefoot, a longus brevis tendon transfer, and then a bimodal abduction dorsiflexion wedge osteotomy at the midfoot. However, this is a whole lot to do at once. So we staged this and we stopped at the red and the yellow part and have not addressed the forefoot yet. However, his contralateral side has that midfoot, forefoot deformity too, and he does pretty well on that side. And he's been happy with where he's at right now. So we may or may not ever address the forefoot, midfoot area, but here's what he looks like. Oh, here's so taking a step back. This is a company called Restore 3D. So we send them our CT scans, and then they're able to kind of come up with how we want to correct it, and then what implants we want to use with them. So our original goal was to do the TC with a TN with this as well, where we use a staple through the implant. However, once we got in there, the implant didn't align quite as well as we wanted to. So the TN was kind of just left free floating. which is not a huge deal. This guy is somewhat neuropathic, so the fact that joint isn't fused, he probably won't have much pain too anyways. But the important part is, you know, we got his rear foot aligned with his tibia. The external rotation, we didn't have to worry so much about with the tibia because we were just able to plane that and essentially get good correction in that regards. And we did do a dorsiflexural wedge osteotomy on the first met. He honestly probably needed something more like a jaws procedure there, but that's something we can always do later. Any questions with that one?
I have one. In terms of staging, how long would you want to wait in between those two sets of procedures?
That's a great question. I would probably wait 6 months.
Okay, thank you.
Just to make sure the swelling's down. You know, give the patient a break. But the biggest thing is the swelling and the compromise to the skin there when you're doing that due to the swelling.
Thank you.
Did you say you're addressing most of the external rotation with PT release?
No, so that's just through the TC fusion. So you don't really have to address it because you can essentially turn it any way you want when you plane those joints. So really with this case, the medial malleolus was anterior. So obviously that kind of got in the way, so we planed it out and we didn't have to worry about the torsion of the tibial bone there.
Thanks.
I had a quick question. What was the reasoning for, and so y'all did a TN and TC fusion on this?
We were going to do the TN, but the way the implant ended up sitting, it didn't really articulate with the navicular all that well, so we kind of just left it free floating. And that's common even with Charcot. That's common with even Charcot patients. You won't end up, you know, fusing that joint.
Okie doke. Yeah, that was my question. All right, thank you.
Okay.
I have a
Blanton.
Yeah.
Was somebody saying they had a question, or is that it?
No, I had a quick question. Did you notice if was there any changes with the limb length discrepancy after this at all, or did everything remain pretty much the same?
There is, and he's doing okay with his shoe lift right now. It's something that he could potentially get a limb length or like a osseous distraction of his tibia if he wants to later on, but he's kind of really scared of external fixators at this point, and he's happy as is, so he's holding off for now. He may never get it done, to be honest.
All right, thank you.
Something else you could always consider too, which we wouldn't do, but if you had a good orthopedic friend, is they can just take a block out and shorten the other leg too.
Yeah.
Well, thank you very much for doing this today. Everybody have a good afternoon, and we'll see you again on Friday.
All right.
Don't forget about the Friday night. Block off your Friday night for our fun night.